complications, macro and micro complications of diabetes. So we'll start. As we know, the estimated prevalence of diabetes among adults in the United States is up to almost 17.9%. It accounts for 14% of U.S. healthcare expenditure, and at least one half of which are related to complications such as myocardial infarction, end-stage renal disease, retinopathy, and foot ulcers. And this is what I'm going to talk about. How do we prevent these, given the fact that we spend a lot of money taking care of it? Primary prevention would be probably a better way to go. Many factors contribute to the impact of diabetes on quality of life. People lose working hours, mental illness, productivity, all that due to diabetes. We all know the criteria. You've probably seen this multiple times. Nothing changed. Few things changed. Last year, they added hemoglobin A1C. The end of 2010, they added the diagnosis of diabetes could be also made by a value of hemoglobin A1C of 6.5%. Normal glycemia is defined as fasting blood glucose level or plasma glucose level of less than 100. The impaired glucose tolerance between 100 and 126, and anything above 126 is regarded as diabetes. And other criteria in relationship to the 2 hours postprandial: if it's less than 140, it is normal. If it's between 140 to 200, it's impaired. And frank diabetes is above 200. So now the hemoglobin A1C and in between. Lately, many of my patients has been asking me about the new values of hemoglobin A1Cs that we see on lab tests. It used to be the upper limit is 6%. Now it's went down to 5.7. And there are multiple reasons for that, which I'm going to explain. And I'll show you why they had to go down to 5.7. And actually, if you think about it, it's a continuum. Pre-diabetes and diabetes is really a continuum. And we are just catching people at different stages in the process. So persons with 5.7 and 6.4 are at higher risk. They found that they're higher risk of diagnosed in the future with diabetes. The enhanced population, which is, they have a hemoglobin A1C of 5.8%, had the highest sensitivity and specificity for diagnosing diabetes compared to any, only the fasting glucose tolerance. That's why we are emphasizing that the hemoglobin A1C is now taking kind of a central stage, not only fasting, which gives you an average of postprandial, and that's where everybody is going. So the A1C and the fasting were found to be similarly effective in diagnosing diabetes. So it's not only the fasting glucose is important. And they found also the prevalence of retinopathy increased above an A1C of 5.5, and that's, we all know, is normal. And a fasting glucose of 104. A1C was more accurate than the fasting in identifying cases of retinopathy. So I'm just kind of illustrating, enumerating facts about why we are going down on the hemoglobin A1C and why 5.7 is high risk for diabetes. The National Glycohemoglobin Standardization Program has standardized more than 99% of the assays in the United States. The problem is, in the past, they didn't use the hemoglobin A1C because there was a standardization issue with the assays they used. Currently, it's more standardized that meets the DCC-T criteria. It's one of the biggest trials in diabetes, so they match the criteria, and therefore it's becoming more accurate and more useful to be used in diagnosis. Hemoglobin A1C and fasting blood glucose found to be, oops, I added that. Another thing, all of them, hemoglobin A1C, the fasting and the oral glucose tolerance tests, they are all predictors not only of diabetes but also of coronary artery disease. And that's a big thing, because coronary artery disease is the most important complications from diabetes. 25% of subjects with impaired glucose tolerance they progress to diabetes over 3 to 5 years. And I'm sure a lot of diabetics know that in spite of medical treatment, starting medication, first line and second line treatment, people still progress to frank diabetes and worsening diabetes with time. Subject with additional diabetic risk factors like overweight, family history are more likely, even they fare worse than others. Baseline hemoglobin A1C level was an independent predictor of type 2 diabetes diagnosis, even at levels were considered to be within normal. So things are changing. The lower, the better. There is a strong, consistent evidence that the relationship between blood glucose level and cardiovascular risk extends into the non-diabetic range. So all said, this is just to show people that the cutoff of high risk or pre-diabetes has been brought down from 6% down to 5.7%, and that's why it gets flagged when those tests are being done. There was a study called the ARC study, the atherosclerosis risk in committee study, showed a relationship between also hemoglobin A1C and coronary heart disease in non-diabetic individuals. Several studies shown also comparing impaired fasting glucose with, showed it that to be a better predictor for CAD. And also there were some observations that postprandial hyperglycemia is more strongly associated with cardiovascular risks than the fasting. So now all this said, how can we prevent? How can we catch people in this spectrum very early in the disease and try to prevent them from moving forward and becoming diabetic? So I'm going to talk about prevention, most of them to prevent the main complications of diabetes, and then we will mention the new drugs to manage diabetes. We all know that lifestyle modification is a big thing. It's been lots of studies emphasizing the fact that weight loss, exercise, stopping smoking, changing diet, decreased fat, decreased carb, better fat, better carb has been shown to improve diabetes management and or prevent diabetes as a primary prevention. So the Women Health Initiative, one of them, and it was on the news one Tuesday on the Washington Post, we got phone calls, says, oh, if you all remember a couple of years ago about the Women Health Initiative showed that being on a low fat diet does not reduce the risk of developing diabetes. They were looking if somebody started low fat diet or all their life, will this prevent them or protect them from becoming diabetic? No. And exercise, there's a lot written about exercise. Exercise is well known to decrease cardiovascular risk, improve sugar control, improve blood pressure, but never weight. Just to say that, the benefit of exercise in preventing diabetes has been well demonstrated in several studies. A lower risk of developing diabetes with regular moderate physical activity was reported, and there is an independent effect of exercise on glucose metabolism. Weight reduction can substantially improve the control of diabetes, and usually the recommended weight reduction percentage is 5 to 10%. Long-term compliance, the problem, as we all know, compliance with dietary intervention, everybody says I diet but I never win, which is true. This is the nature. Your body get adjusted to a certain amount of calories and your hypothalamus starts kind of fight you, and therefore you stagnate, you plateau, and people kind of give up. And it's well documented. I tell people this is normal, don't get despondent, we just keep going and your body will respond. So, but it's in general, long-term compliance with any dietary protocol is very poor. I'm still in the prevention. I know you all know metformin is one of the medication is used in the management of type 2 diabetes. These are all studies done to prevent diabetes. So can we use pharmacological therapy early in the process to prevent the development of diabetes? And yes, it's been studied. Metformin appeared to be effective in reducing the risk of type 2 diabetes in patients with impaired glucose tolerance, although it is less effective than diet and exercise. Though there is controversy among us endocrinologists, some believe in starting early metformin early in the process, and some believe that we have to give them time to do the lifestyle modification. But many of us believe that patient, if they would have done it by the time they come to us. I think we should introduce something like metformin to help them to achieve better results. Not just sugar, but weight and pancreatic, you preserve the pancreas. Metformin has been shown to reduce the rate of progression to diabetes and was effective in both men and women in all ethnic groups, but was relatively ineffective in older patients and the less overweight, above 65, and the people who are not very obese. Although it is less effective than diet and exercise, the DPP, diabetes prevention, the second study, there was an original study in the 90s and there is a recent study in 2003, demonstrated a beneficial effect of reducing the risk of diabetes in younger obese patients, and particularly in women with history of gestational diabetes. Also, it is inexpensive, and has almost no long-term serious side effects. So it's been used, has a good track record, and the only, it has a major gastrointestinal side effect, which could be kind of reduced by taking it very slowly and gradually, kind of ease into it until achieving higher dosing. The ADA recommends consideration of metformin for diabetes prevention in individuals, especially at high risk. In the past, and there was studies about using thioglycozones. I'm the wrong one to ask, I never used them, but it's not recommended anyway for multiple reasons, as you remember, Avandia and Actose and all of them. It's not recommended to use them for diabetic prevention because of their adverse side effect, mainly weight, water retention, heart failure, and increased fracture risk. I put this alpha glucosidase inhibitors. These are a couple of them in the market. They break down carbohydrate in the gut, cause a lot of gas, diarrhea, and really it's so expensive. It's neither cost effective nor worth it. But and it's not recommended. Orlistat has been on the ACE guidelines. Could be used in insulin resistant, treat insulin resistant, but it has a very modest effect on the whole prevention and even the weight loss to prevent diabetes, because of the gastrointestinal side effects. And of course, as you know, LI which is the over-the-counter medication. It's 60 milligram. The Orlistat used to come in 150 milligram. It didn't show long-term durability in maintaining even weight loss. So now that we know that we have a chance to improve the cardiovascular issues and retinopathy very early in the disease. We know it's a continuum. We know it starts from the glucose intolerance very early. If we can prevent it or even delay the prevention, we win. So now the diabetes complications. Diabetes complication present a very big burden on patients, on the country, on money, everything. So therefore, we're going to talk about each one of them. If we can do primary prevention for these complications, followed by secondary prevention, which means the patient's already diabetic, and now we're dealing with a diabetic patient that needs to maintain, if not reverse, these complications. So the biology, there's two issues: the microvascular complication that you're all aware of, the retinopathy, the nephropathy, and the neuropathy, and they cause a lot of morbidity to the patient and mortality in cases and especially in renal failure, blindness, and all of that, and therefore they're really important. And then there is the macrovascular complications, which is a metabolic injury to the large vessels, which include heart, brain, extremities, and causing cerebrovascular accidents, myocardial infarctions, and congestive heart failure, and of course, not less important, the ulcerations, gangrenes, and amputations for diabetic patients. So we're going to try to see if we can do anything in a form of primary and secondary prevention for these, as it's now what they call the power of prevention. So morbidity from diabetes is a consequence of both the macro and microvascular disease. The diabetic microvascular complication may be present even at the time of diagnosis, and that holds true for type 2 diabetics. The progression of these complications can be slowed, but probably not stopped with interventions, and it's sad, but we at least try our best. That's why primary prevention take a big focus here.